Okay, hello again, everyone, and hi to those of you who just joined. My name is Alex Mitchell. I'm a marketing communications manager with the Lighthouse Lab Services marketing team, and thanks for joining us for today's webinar. Today, we're going to be speaking about generating revenue and serving patients by implementing a direct to consumer offering. We're going to be co hosting today with the ARCpoint group and two speakers representing their company. Like to just quickly introduce both of them before I touch on a few housekeeping items. John Constantine is the CEO of the ARCpoint Group, and John has served as CEO of ARCpoint since November of 2018. From February 2017 until November 2018, he served as the COO for ARCpoint Franchise Group. He's led organizational growth as the Vice President of Marketing for Bioconfirmed Laboratories in Atlanta, Georgia, Vice President of Strategy, and other various Vice President positions at Cordant Health Solutions in Denver, Colorado. Before that, Mr. Constantine was a vice president of sales for a marketing firm in Indianapolis and national director of sales at AIT Laboratories in Indianapolis, Indiana. And I'd also like to introduce Bob Mann. Bob is the president of the ARCpoint Franchise Group. He joined ARCpoint in March of 2023, and prior to ARCpoint, Bob spent more than 10 years at Cordant Health Solutions in various leadership roles, including National Director of Sales, Vice President of Strategy, and eventually Executive Vice President for his last 4 years at Cordant. Bob also worked for 6 years at Quest and ran his own sales and marketing business prior to his time at Quest Diagnostics. I'd like to thank them both for joining us today and sharing their expertise. And before I turn things over to them to tell you a little bit more about ARCpoint and the direct to consumer offerings we'll be covering today, just like to touch on a few housekeeping items. You can reduce your chance of any lag in the background, which my camera looks like it's doing right now, by closing any bandwidth heavy apps that you have running. This webinar will be recorded and we'll be sending it out to everyone under the email address you registered with afterwards, so no need to ask for that recording. If you want these slides to take home with you, you can look under the handouts section and we have those on offer as a PDF. No need to wait till the end to ask us any questions. You can go ahead and pop those in the Q&A section. We'll review them throughout and then move them over and make sure that we address them at the end. If there's anything we don't get a chance to touch on today, please, we'll have multiple opportunities to follow up with the speakers from ARCpoint and also Lighthouse. So feel free to fill out those contact forms if we don't get a chance to address your questions. And we're also going to run polls during today's webinar. We encourage you to participate in those, but if you want to skip those and just continue on with the presentation, feel free to X them out and continue ahead. And then just quickly about Lighthouse, this is how we're able to keep these webinars free. We are a full service end-to-end medical laboratory consulting and recruiting firm. And whether you're looking to start your lab or grow your current business, we offer labs a way to accelerate their success through RCM, payer strategy, test menu offerings, and a host of other laboratory consulting services. So please, if you need any assistance with any of those areas, feel free to reach out to us after the webinar. And with that, I'm going to go ahead and turn things over to John.
Thank you so much, and we're really excited to be here. I think Bob and I probably have been in the healthcare business, the diagnostic space collectively. I think we could probably say we're over the hill, Bob. Collectively, probably close to 40 years of healthcare experience, which is strange because I still feel like I'm 25 years old. So I don't know how that happened.
You're old, yeah. You look great though. You look great. Well, you need better lighting though, John. You're hard to see right now.
I was just thinking you won the lighting competition in the office today. Bob and I have worked together for coming up on a decade, either at Cordant or now at ARCpoint. And I think the one thing that we've had in common is, besides being growth strategists, and we both think that we're funnier than each other. I think that the biggest thing that we have is that we're passionate about making sure that the United States and the consumers of the United States have access to the services and the diagnostic testing that they need. And that has kind of flown through our entire career. So what we've done at ARCpoint is develop a way for people to get access to diagnostic testing, regardless of whether they want to go through their physician or whether they want to go direct, as a direct access testing model. But we do this in a unique way where we are lab agnostic. We're also outside of the insurance program. And one of the things that we'll talk about today is the reason why we've chosen to stay outside of the market, but how you, as a high complex lab that has contracts most likely with payers, with CMS and private payers, how you can benefit from partnering with either somebody like ARCpoint or ARCpoint itself. So a couple of pieces of disclaimer information on here. Be very, very clear. Bob and I are not attorneys, okay? And so this is a very, very big point for you to understand. Nothing that we're talking about is legal advice. By all means, seek out legal advice. If you don't have a great attorney that knows direct to consumer, direct access testing, we have a network of attorneys that we've worked with over the years that understand this space very well, both at a national level and at an individual state level. So more than happy to be a resource for you guys if that's a direction that you want to go. But it is very important to partner with an attorney as you think about walking down this path. I also think that it's going to be key to understand that we are going to cover some things, but we cannot cover everything in the hour that we have, probably 50 minutes of talking and then Q&A at the end. So once again, this is the start of a conversation. You can lean into us and we can help you understand, navigate this world and try to figure out a great way for you to enter this market if it's a direction that you decide that you want to go. So a little bit about ARCpoint. We have 135 brick and mortar laboratory collection sites across the country. And like I said before, we're lab agnostic. We just want to provide high quality lab services to consumers and doctors in our local markets by partnering with labs just like you to give you access to those customers. Think about it a little bit like this. We become a distribution unit for you in 135 different markets across the country. Now, why we're interesting today and why we've partnered with Lighthouse is because of the platform that we launched this summer called My ARCpoint Labs. This is a proprietary technology that allows every lab now to become a direct-to-consumer lab, regardless of whether they want to dive into this on their own and build their own website and market this directly to consumers from their website, or whether they would rather become a resource of the ARCpoint network and become another opportunity for you to go to market. And then once again, we are a cash-based lab system. So we've opted out of CMS. We don't have any contracts with payers, which gives us a unique ability to market directly to consumers with pricing that might make more sense to those consumers. I'm sure Bob and I come from this world of healthcare diagnostics. We're self-pay patients. All the rules that you have to do in order to try to collect claims on self-pay patients, we've been able to bypass that by creating a business model that doesn't need to follow those same rules to the same level. And we'll get into that a little bit deeper into this presentation. But here's the foundation of why we're doing what we're doing. Healthcare is expensive. This isn't a secret to anybody. Y'all are probably mostly small, medium-sized businesses, which means that your employees, the people you employ to run your business for you, they are a massive expense when it comes to what you're paying for health insurance on their behalf. In fact, they probably are now shifted to have a big burden on their own. It's said that just about $13,000 per person in the United States is the cost of providing health care to the US population. And it gets even worse than that, because not only is it expensive, and more than half of the people in the United States have what's called a high deductible health plan, meaning that they're going to be paying thousands of dollars out of pocket before they really see the benefit of their insurance. It's confusing. According to United Healthcare, only 6% of the US population understands the key terms that we use, like diagnosis codes, ICD-10 codes, CPT codes, EOBs, all the things that we're used to in this world. We forget that consumers just have no idea what any of that means. In fact, 94% don't understand that. And the key component to direct access testing is that over 100 million people in the United States don't have access to a family practice doctor, which means that they are stuck trying to create their own health path on their own. Post-COVID, it became very clear to consumers that they don't need a doctor's order. In their mind, they don't need a doctor's order. They can go directly and get a COVID test. And it made them start to think, what else could I get directly without needing to go through the whole complexity of going to my doctor? And even worse, what if my doctor doesn't know the answer that I need? What if I think I know a little bit better because I have resources, I have online resources, I have friends that are talking about this. There's a potential there that consumers want to take health into their own hands. And so we've jumped into this. And here's really kind of the foundation of what we're talking about. Healthcare in the United States used to be doctor-based care, and I think unfortunately a big chunk of it still is. EMR systems are based around doctor workflows. They don't really think about the patient first. Reimbursement models are around hospital networks and hospital systems that enable them to capture the revenue to then pay for the doctors that they're in high demand, that they're in high competition for. And it's all around this third-party insurance world where basically, insurance companies, they're not poor. They know what they're doing, and they've interjected themselves very strategically as a third party to try to make it more seamless for employers to service their employees with healthcare benefits. But the reality is they just added extra expense. And so what we've built and what consumers are starting to demand is a little bit more on the right side there. They want patient-based technology. They want to be able to go to their phone and get whatever they want directly from there. They want upfront clear pricing, and they want it to be cost effective. They're willing to pay for services. They just want to feel like the value of that service matches the cost that they're going to have out of pocket. And they want it to be convenient. They want to be able to consume healthcare in the places that they're already going, navigating complicated healthcare facilities and hospitals, needing to go to a doctor's office where it's going to take months potentially to actually talk to a practitioner. The new generation, they're not signing up for it. And so, Bob, I think you have a wonderful example of something that speaks to this.
Yeah, and before we even get to that, John, I will just jump in and caveat this a little bit. A lot of times when we talk about this dichotomy here, right, of sort of the old way of healthcare and then how things are moving forward, it's not necessarily that we're competing against traditional healthcare. As John referenced earlier in the slides, like 55% of the country has high deductible health plans. There's another 10% that have no insurance whatsoever, right? So you're talking 2/3 of the country either has a high deductible plan or no insurance at all. And so for that group of people, the traditional system isn't working great for them, right? Now, there's still 1/3 to 40% of the country where the system works great. The doctor-based care works great. And so this isn't a competition. It's recognition of how the market is changing some, and especially how COVID has really accelerated that change in the marketplace. And I'll give you a couple other examples of that here in a second. But John, as you referenced sort of my story, I've been in healthcare for the past 20 years and have had access to insurance my entire adult life, right? I've in fact, outside of maybe a month where I was on Cobra as I switched jobs, I don't think I've been in a situation where I haven't had a traditional health plan in my entire adult life. However, I don't go to the doctor. I am that, again, 50% of the population who just doesn't go to the doctor on a regular basis. And I don't for all the reasons that are referenced here in terms of I'm a busy person. I've got 5 kids. I've got a wife. I've got a demanding job. There's a lot of things I do in my personal life that take up a lot of time, and to have to schedule something 8 to 10 weeks in advance and find a primary care doctor who will take me on and all of that type of stuff is challenging. I'm interested to know my numbers, right? I'm in the lab space. I know I need to know that type of stuff, but it's been 15 years since I had my blood work done. Now, since I've been at ARCpoint, and my wife has been getting on me more and more, as we talked about, we're aging, John, right? Especially you, but we're both aging. And my wife finally convinced me, hey, you need to, I know you're not symptomatic. I run 5 or 6 days a week. That's sort of my thing that I do. And I had no reason to think I had any issues, but wanted to please go and make an appointment. I said, well, I'll show her, right? I work at ARCpoint, right? Let's go get my blood work done. And I'll come back with blood work and be like, look at this, honey, right? I'm going to live forever. And so I went and got a basic kind of wellness panel done. And I'll never forget getting those results back. I got a text message saying, hey, your results are ready. And I pulled over on the side of the road and pulled them up and I almost had a panic attack. I had high cholesterol, my cardio CRP was high, my LP(a) was elevated. I had these significant cardiovascular risks that I knew nothing about. And to me, it was a wake-up call that, oh gosh, I got to get in to see the doctor. So sure enough, I got an appointment scheduled with a primary care physician. I now have a cardiologist. And I was somebody who was outside of the traditional healthcare system that our program helped feed back into the traditional healthcare system because that's what I needed. And I think that's important here. Again, as we talk about this as a nuance, again, we're not here to compete against that. But at the end of the day, we have to realize that, this chart here shows the cost, the average premium cost for both a single person as well as family when it comes to average monthly premiums over the last 20 years. And as you can see, that's done nothing but go up over the last 20 years. And 2024 is going to be one of the biggest jumps ever. It's estimated between 6.5% and 7%. I know our company personally, we're taking a 7% increase in our premiums for us and our employees as we go into 2024. And our benefits have gone down, right? Every year. I think back when I first started working at Quest Diagnostics, again, like 20 years ago, I had no co-pays. I don't think outside of my premium, I was paying almost nothing out of pocket. To now, those health plans they're just too expensive, and you're paying co-pays everywhere. A lot of times, really significant co-pays. I get bills if I get lab work done. I get bills if you get radiology done. I get the benefit of paying $700 a month, and then my son had to go to the ER, and I get a bill for $2,000. And he said it would have been $4,000 if I didn't have insurance, I guess. But it's becoming more and more difficult, and the cost of our healthcare system continues to go up due to consolidation and a lot of other reasons. At the same time, add what's going on behind the scenes on a number of different fronts, and this really accelerated 2020 to today. In terms of wellness brands, recovery brands, fitness brands that are out there. The home fitness and boutique fitness brands just exploded during and post COVID. We are in the franchise space. We don't do fitness in the franchise space, right? We're wellness and healthcare, but we know the franchise space very well. And these are all examples of franchise brands that are out there. And this is just the tip of the iceberg, right? This is something that people have. There are hundreds and hundreds of new fitness brands that are popping up because people are wanting to engage in different ways around their healthcare. People today all are have. I bet 75% of the people on this call are wearing a device that tells you your heart rate, how many steps you took, right? And probably half of us look at that every day and are tracking that and talking about it, right? People are more engaged with their wellness and healthcare overall. And then on a bigger picture scale, you look at what's happening in the marketplace when it comes to things like Cost Plus, right? For those of you who don't know Cost Plus, right? It's Mark Cuban's company out of Texas. They're taking on the PBM market. Right? They're saying people are tired of a lack of transparency in pricing and inability to really understand and control their costs. And so they're jumping into that market. We saw Blue Cross Blue Shield of California dropped, I think it was CVS Caremark as their PBM, and it's taking on Cost Plus. GoodRx, we've seen GoodRx grow over the last 10 years. We talk about like our solution and the solution that you can provide to your patients. It is like a GoodRx for diagnostic testing. We help people find the lowest cost for them to get that diagnostic testing done that they want to get done. Direct primary care continues to grow and become a term and a process that people want to take advantage of. All of that is happening as a background as people are looking for solutions within the healthcare space for these rising costs.
Yeah, Bob, the interesting thing about what you're talking about is that, and actually there's a chat in there about some of this information about healthcare in general varies greatly across the country. And that is absolutely true. In fact, I use ARCpoint services, but I have a wonderful family practice doctor. He chats with me in my chart. He's able to get back to me. He reviews the reports that I send him through the app that I just get ran on my own. I mean, all those things are wonderful. I think that the key thing that you're talking about, though, is that there is a slide that's happening. You know, there's a wave that's changing. And while there are pockets of people that aren't feeling the effects of this, I think if you work for major corporations, healthcare still is pretty decent. You might even have a wellness clinic on site, but there's a massive part of the population that just doesn't have the luxury of good services. And part of this runs into the fact that, you know, we talked about there's 100 million people in the United States that don't have access to a family practice doctor, but there's actually a big gap in the quality of care when you go see your doctor. So as amazing as my doctor is, I get about 5 minutes with him whenever I go see him. If I try to speak to him about anything that's outside of the chief complaint that I scheduled the appointment for, he wants me to schedule another visit. And it's because he's getting slammed to see as many patients as he can in a day. Now, because of that, there's a limited amount that he's able to learn about what's coming out down the pipe. And we grabbed this article from the back half of August in the Wall Street Journal, just as an example. This was an article that was talking about a man that had pancreatic cancer. He did some research and he determined that he could get a genetic test to determine if his family, he's an older man, he had a daughter that was a 43-year-old internal medicine doctor. He wanted to see if his family was at risk. And so he ran a cancer bioscreen test to determine whether he had a genetic abnormality, which might have contributed to why he had pancreatic cancer. It turns out he did. He was able to talk to his daughter about this. Now, remember, a 43-year-old internal medicine doctor. Now that I'm on the other side of 43 is not an old doctor, but she's not a spring chicken either. She's been in the business for a while, right? She's got a dozen years of experience in healthcare, but she said she had no idea that this test was possible for her. And so as your team is out there marketing your services, especially if you're an innovative lab, we're speaking your language that it is very hard to create awareness to practitioners about new innovative services. She said that she was wildly surprised that you could test for a dozen genes at the same time and that those treatments, depending on the outcomes, influence the treatment. She said that it was so empowering to be able to get access to the information. And I just want to say again, she's a 43-year-old internal medicine doctor. The fact that she didn't know that these tests exist was my key takeaway from that article. Creating awareness of these tests is what the number one strategy is for you and your growth strategy. And by going directly to consumers, you're able to bypass that bottleneck that sometimes is the practitioner. And so there was a question earlier about in Connecticut, you need a physician order in order to conduct direct-to-consumer testing. And that is 100% true. In fact, in roughly half of the states in the country, direct access testing is technically not allowed. And so what you have to do is build a system that allows a consumer to find a test on a test menu online. It's got to make sense for them. It's got to be in their language. They have to be able to schedule the time to come and get that test conducted. They have to be able to process the payment for that test. The digital patient intake has to happen. There's a ton of components inside of that. The information you need to capture, the disclaimers you need to put, the collection process has to happen. But here's the secret point to this, is that in those states where you need a physician order like Connecticut, you need prescriptive authority, okay? Now that prescriptive authority, it doesn't have to happen from a doctor before the order is presented. It just has to happen before the test is ran, okay? So a consumer can order their own test. It can go to a practitioner who then provides the prescriptive authority that then authorizes that test to be collected and then ultimately ran in the high complex lab and then reported through a patient portal. So that's a key component. I saw that show up in the chat window earlier. So here's the components that we're going to be talking about at a very high level today. And once again, we have a very condensed amount of time. This is 7 years of building a program all wrapped up into a turnkey solution. We just want to give you the nuggets that if you want to develop this on your own, the things that you really should be thinking about. So prescriptive authority, patient authorizations, where you need to, why you need to outsource direct access testing. So why does this even matter? The scheduler, collection sites, patient portals, test menus that you need to navigate, and pricing strategy, especially pricing strategy as it correlates to the contracts that you have with CMS and your private payers. We're going to be running through these very quickly. All right. So Bob, I want you to jump in.
Yeah, I just from John always wants me to touch on the legal things. So as was referenced in the chat, that there are some states that you're not allowed to do this, and from a direct access testing. So a patient can't order their own testing. And a surprising large number of states you can. So there is direct access testing. You can see in the states listed above there, and then some states have some limits on it. Some states it's completely prohibited without a physician placing that order. There are the way we're set up, we have prescriptive authority in all 50 states. It's important to know these rules and to know the rules of your specific states, so you can understand what the challenges. And we'll say even in the direct access testing states, we still run into some challenges with laboratories not wanting to accept an order. So it's legal. A consumer can place the order, but the laboratory won't accept the order without a physician order. But
I think, Bob, that's a good best practice, right? That the way that we've set up our system is that regardless of whether you can have a consumer order a test directly from you, we've decided that we will interject that practitioner prescriptive authority on the front end, even if it's not technically necessary.
Yeah, and I think, and my belief is too. I mean, other laboratories that do this out there today. I mean, Quest Diagnostics, right, is taken a stab at direct-to-consumer testing as well, and that's how they operate as well. So, with that, and John mentioned the different things you need to have in place. So, all of our people can walk into an ARCpoint facility to get their blood drawn. Or through any of our affiliates, right? They're signing off on our financial policy, how this all works. They're paying for the test right there. They are, how refunds work, things like that all need to be kind of thought through. General kind of consent forms and privacy. We follow all the same, HIPAA rules and all of that anybody in the space needs to follow. And going through all the various disclosures that you need to put in place for patients. But those are really important when you think about what's that patient experience, what are you alerting the patient of when it comes to specific things in your state, as well as for example, we disclose to all patients, hey, we are not contracted with Medicare or Medicaid. You will not be able to bill these services to Medicare or Medicaid. And that's really important to be very, very clear with patients as they come in. So we talk about the why, like why would you need to outsource this versus doing it yourself? And a lot of it does come down to the billing component of it. If there's one thing that, any of us who've been in the laboratory space or the healthcare space for any amount of time, billing within healthcare is extremely complex. And I don't think the average person understands that the way that you all do as people who run laboratories. But chances are, if you're a laboratory that is dealing with third-party payers and with Medicare and Medicaid, you've got contracts in place that limit your flexibility when it comes to the price that you bill a patient, right? That you have to bill a patient at a rate that you're typically going to bill that patient at a rate anywhere from Medicare rates to 3 times Medicare rates, and you want to be careful you're not going under certain thresholds. At the same time, most laboratories have direct billing relationships with other laboratories or with hospitals or whatever it may be, maybe some physician clients, where those direct billing prices are lower than what their third-party payer reimbursements and patient pay prices are going to be. And then you end up in these situations where you're dealing with patient pay today. Just even when I was back in my Quest days or the laboratory I was at for the past 10 years, that patient billing experience was just challenging. We would bill the patient would get a bill that just felt astronomical to them because they'd be seeing list charges. They would then call, instead of calling us, no matter how much we prep them to call us, they're calling the doctor or the hospital that they got the test through, and they're furious, and it created stress and for everybody. And they would call us, and we'd have to negotiate a price and get information about where they were on the poverty scale and all those type of things to be able to negotiate down a price that was reasonable for that particular patient. And unfortunately, some laboratories, knowing they're stuck in a situation, they've got to send people to collections, and All of that is just an awful experience for somebody who needed to get health care at the end of the day. And a lot of that is the contracts you're in today with your third-party payers prohibit certain discounts you can give patients. So entering into, whether it's with us or with a different organization, entering into a direct bill relationship where you're offering pricing for your laboratory, for the testing at your laboratory at a wholesale rate, and then that relationship with your direct-to-consumer provider, they're providing the billing, the scheduling, they collect payment, and it keeps you at an arm's length away from that patient when it comes to the billing. And we can, whether it's us or somebody else, your direct-to-consumer provider can talk through sort of how all of that works. And as we said at the beginning, of course, you'd want to look at individual state regulations, contracts with your payers, and your own healthcare attorney. But we'd be able to navigate this fairly well in most states.
So the way that we work as a system, it's important for you to identify collection sites, right? So whether you want people, we've partnered with some high complex labs that will just have people come in the front door of their high complex lab, and they'll do phlebotomy right there in the laboratory. I think that's mostly not ideal for most laboratory setups, and it limits the market that you can actually serve with that one collection site. Sometimes you'll find success partnering with doctors' offices to do the collection. So physicians' practices that have phlebotomists will be willing to outsource those phlebotomy services to you. Typical collection fee is anywhere from $30 to $40 to pay for that service. There's an opportunity there to do it. ARCpoint has a network of 135 brick and mortar collection sites across the country that can partner with your local sales team and provide phlebotomy services, help to get the word out about your laboratory, the services that you provide, and then be a resource for you to do the collections. And in essence, if you're a regional lab, let's say in a state that covers 2 or 3 states right now, this type of opportunity turns you basically into a national lab. Because remember, a lot of times the limitation that you have on crossing state lines is going to be the contracts that you have with the payers in that state. But when you get into the direct access testing model, you're not limited by those types of claims restrictions. You just charge cash to everybody. Now, there's a question in the chat about Pennsylvania on the changing laws there. And in fact, there was a change, I guess it's been close to 2 weeks ago now, where historically in Pennsylvania, laboratories weren't allowed to market their laboratory testing to consumers. And that has been lifted. Now, there is still the need for prescriptive authority. And so you still need to have a doctor that writes the order for that test, but now you can market into that state. That was the only state in the country that had restrictions on whether or not you could market directly to consumers. Outside of that, it's all good. You can market across the country to consumers for your diagnostic testing.
So, and John, one of the comments here too, regarding if physicians are aware of the cost involved for the patient. So if they know the patient has a high deductible plan, they know the patient has insurance, you're exactly right. The person made this comment of, especially our owners, we've got of the 135 groups we have across the country, work with physicians in their area so that when that patient who has complained about lab bills in the past comes back in to see them and the more laboratory testing is needed, they know that we're an option. Just like they would give them if a patient complains about, hey, my prescriptions weren't covered last time, I had to pay $100 for this, right? They give them a good RX card, right? And say, hey, check this out first before the next time you get your prescription filled. I think that is really important as you engage and educate physicians about the options out there for their patients.
Yep, absolutely. And we actually have a question about prescriptive authority. I think, Bob, we're running into, we speak about this all the time, so we make assumptions that everybody knows what we're talking about. Basically, if you think about it like this, if you want to go get a medication from a pharmacy, unless it's an over-the-counter medication, you can't just go to the pharmacist and get them to fill that prescription. You need to have a prescription for that medication. Well, in half of the states in the country, Prescriptive authority is the same idea, only specifically to diagnostic testing. You can't just walk in off the street as an individual and go to your laboratory facility and ask for a diagnostic test. You need to have an order or a prescription from the doctor for that. And so what Bob was explaining is in our system, when a patient orders a diagnostic test, once again, regardless of the state that they're in, that order goes to one of our doctors that's licensed in all 50 states. The doctor that's licensed in that state that has that authority and that gets the order basically writes the prescription for the test before that test enters the laboratory. And so as you're accessioning that sample into your laboratory information management system, there's going to be a doctor's name that you're able to place into your LIMS as the ordering practitioner. Now, the mix-up on this is historically, the thought was that order has to initiate with the doctor and then the patient brings the requisition. That's not the case. The authorization just needs to happen, or the prescription for that diagnostic test just has to happen prior to the sample being collected and the results being pushed back out to the patient. Now, I do think that a key part to this is on the back end as well, and we don't get into a ton of details around this, but there's also a review of the results by a practitioner before those results are released into the patient portal like we're talking about here. Your laboratory information management system might come preloaded with a patient portal, but most likely it has a physician portal where the doctor is able to log in, or the nurse practitioner or the practitioner is able to log in to see the results on all of their patients. Very rarely does a laboratory information management system, I think, provide a patient portal where they can log in and directly access those results. And so for the ARCpoint system, what we've done is we've created a proprietary customized patient portal where patients get a text message when the results are completed. They click on the link in the text message, they securely log into our database. They're able to access any result that they want from your laboratory. Now, the details around how they do that, you got to make sure that you're storing that data in a compliant fashion. You can't email test results out to a patient because of HIPAA and PHI limitations. You don't know what the security is on the other end of that email address. And so therefore you can't just email or text message results, which is why we set up this text message type system. So hopefully that helps clarify a little bit on how the results need to go back to the patient when they're done.
And a couple things that have popped up here I just want to answer as we go along here. We can answer quickly. So the clinical necessity versus selection of the test. And I think when you're dealing with the direct-to-consumer in a cash model, the idea of medical necessity sort of goes away. And that it is if they want to be tested, if they wish to be tested. And somebody else asked a question about how are they certified as their PCP? Well, they're not their PCP in a cash model. It's that's just not how it flows. It's a different models.
Yeah, it's interesting, Bob. I around the medical necessity, I ran our comprehensive men's health panel on myself. I do that every year. The first time that I did it and I sent it back over to my doctor, he said, okay, where on earth did you get this test? Because I don't have medical necessity in order to order all these tests on you. So I wouldn't have been able to order a vitamin D test without first doing a questionnaire to determine that you're deficient for vitamin D. I don't have clinical authority to order a testosterone test on you unless I have documented proof that you might have low T, therefore you need a testosterone test. And so the fact that I was able to run all these samples all simultaneously at once without medical necessity was a big part to my practitioner. In fact, he loved that because not only was it cheaper for me, I have a high deductible health plan. I don't consume healthcare a lot. It was cheaper for me out of pocket. It was less cumbersome for him as a practitioner to try to get access to the data that he needed to treat me better.
Yeah.
I just wanted to jump in real quick. You're doing a great job tackling the Q&A in the chat section. We have more too. If you, as you're talking, want to take a look, Q&A published. There's about 10 or 12 currently live in there, and we could touch on them at the end too. But the conversation's great, so I just wanted to let you know there's more over there.
Perfect.
Yeah,
Exactly.
I'm seeing some pop in and out, and just trying to grab some that I think are relevant to the areas
Bob,
we're
let's
talking
do this.
about.
Let's roll through.
Well,
Let's roll through the rest of the slides.
yeah.
Really,
Well,
three
John,
left. We can
what
tackle
you're
these.
talking about on test menu, I think, is really important, because it's a good example of what you were just saying. It speaks to the clinical necessity. So as a consumer, I could say, well, hey, I heard about vitamin D on Oprah, and I want a vitamin D test, right? I think that's what I feel like. These symptoms, I've heard about these symptoms, right? It's a little bit like, you don't want to get too caught up in like the WebMD mentality, right? I go out and I find a disease, and now I start looking for symptoms, right, of that, and ordering tests. That doesn't serve anybody. And I think we spent a lot of time with our medical director going through what are the appropriate panels to offer, and then we always offer the individual tests as well, right? We're not trying to push people into hey, order $1,000 worth of testing, right, on yourself, of a bunch of stuff that is extremely esoteric and may not be beneficial to you. All right, it's what are the things that you need for your, what would normally be in an annual checkup, right? Our medical director is a primary care physician who has been seeing patients for 15 years. And what would he order on somebody who comes in different situations or complaining about certain conditions, and built our panels around that. And then trying to explain those panels to people in a really simple way. And we said we drew it at a 7th grade reading level, so that I can read it and understand it, and that that it is aimed at a patient description, and symptoms that may be occurring, not at a doctor level, right? To where you're ordering, you're trying to explain, what a test is to a doctor, and you're talking in scientific terms that the average person isn't going to understand. Which I'll be very, very clear on that. And that's, again, another component of our platform that really is turnkey in terms of these descriptions and setting up of panels and all of that.
Yeah, that's exactly right. The way that a doctor is going to interpret this is wildly different than the way that a patient is going to interpret this. So here's the basic takeaway. Gosh, this went really fast, Bob. We covered a ton of information, and there are so many questions in the chat window. First off, there was a pop-up that showed we are happy to answer any questions that you might have. Just click on the link there, and we can get back to you. Schedule a time to have a one-on-one, face-to-face about what this might look like. But here's the key. That is not a picture of Bob, although it kind of looks like Bob.
It's nothing like me at all. I have red hair.
Well, I don't know where we came up with that. This is
have an earring like that.
This can be overwhelming, okay? And we completely get that. There are so many little tiny nuances inside of this that you really can get chasing rabbit trails and pulling that string off the sweater to unravel the whole thing. And so it's a little bit why Lighthouse Labs exists, I think. They provide fantastic services to their laboratories. I've been a proud partner of Lighthouse for coming up on 10 years, I believe. And they help you with these types of questions. So you can lean into this network. You can also lean into Bob and I and our support team on how we can help you become a direct access laboratory. This is just the beginning, okay? So we didn't get into all the nuances of each one of these sections. I think it would probably be a full-on college course covering an entire semester to fill out all the information that has to do with direct access testing, what you need to do, how you need to handle it. But once again, we've created a technology stack or a software program that allows you the ability to private label our software to create a direct access testing model through your website. We kind of slid by this pretty quick, but when you look at the test menu button here, we gave a generic website called Acme Labs. It's just a matter of putting a test menu button on the website. We have customized landing pages that we create on your behalf, where we can help you navigate what tests would make the most clinical relevance for consumers, how they need to be communicated directly to consumers. And we have the whole system that then takes them through ordering the test, scheduling the collection at one of the ARCpoint Labs locations, paying for the test, coming in. It's an operations software tool behind the scenes for the collection sites, interfaced with your lab through a bidirectional HL7. The results come back through our portal. Our practitioner network will provide the prescriptive authority on the front end, do any medical review that's necessary on the back end. If there's state reporting to Department of Health that needs to take place, we cover that. If there's an interface with the patient that we need to have, we help to cover that as well before sending the results back to the patient through a secure portal. And we can generate all of that as a private labeled solution directly through your website. So we can help support that. And I think we're ready to jump into some of these questions, Bob.
Yeah, I can fire off on some of these. Some of these I may shoot over to you. But so critical values, yes, we've got a process for that internally where we review all laboratory results come back. So if potassium levels out of whack and it's a critical value, we contact that patient immediately. We also work with our laboratories who want to do that themselves in some cases, and they sometimes will have a process for that. So it depends on how you're set up.
Bob, there's a question here about Medicare and Medicaid. Need to sign a waiver stating they understand that they're having a direct access test. Now, once again, we are not healthcare attorneys, okay? So definitely when it comes to CMS business, do your homework. We can help provide you a resource of attorneys that will help you navigate this. But here's how we've built this. The patient does have to have an understanding, and we put it into our patient consent that they are aware that we don't have a contract with CMS. Therefore, we will not be billing Medicare or Medicaid for these services. But the ordering practitioner should also be opted out of Medicare. So just because a doctor has a license in a state to order testing, that does not mean that you can now charge cash to Medicare or Medicaid. If a doctor has a contract with Medicare or Medicaid, then that ordering practitioner should not be ordering for a cash-based service. So it's important to find a practitioner that is opted out of accepting Medicare or Medicaid. Once again, there's nuances inside of that, but that's a very, very important question. And then, of course, the practitioners that we've put in charge of the ordering of our diagnostic tests, they are all opted out of Medicaid and Medicare. So therefore, we can collect cash on patients regardless of their Medicare Medicaid status.
There was a question here about Quest and LabCorp, some of the big national laboratories as major central labs. How do you persuade a doctor to switch to a small lab? As somebody who's worked for a small lab for 10 years prior to coming here, there's lots of a very long answer. But I will say, when we go and talk to physicians as ARCpoint labs in any given community that we serve, we're not there to tell them to stop using anybody, right? They often are using a laboratory that they're happy with for at least half their patients, 75% of their patients. But there's this segment of their patient population that's not happy with that solution because they're either cash pay or they have a high deductible health plan. And so when they send a lab to that patient, send a lab to that lab for that patient, the patient gets a large bill, right? And it's a surprise, right? We've all heard the surprise bills and even legislation that's being passed around surprise bills. And that's a real annoyance to doctors and their relationship with their patients. And so we can help them avoid that by saying those patients who complain about large bills or surprise bills, send them to us. Right. Well, like John said, we'll even create a landing page for them where they can just scan a QR code. They can see exactly what test costs. They pay up front. Right. There's no bill on the back end that we're going to send them 3 months later. And everybody's happy. They get the testing they need. We can send those results to the physician. They know what their cost is and it's reasonable. And it's a win for everybody. But they're still going to use Quest or LabCorp or ABC Laboratory for the rest of their third party work.
Yep. Looks like we have a question here. How does a lab benefit from offering reduced prices? Is there a volume guarantee? I think this is a different business model that this individual is talking about, but it does bring up a good point for a high complex lab. This is more about your out-of-pocket bad debt that you have from patient responsibility. So one of the areas that we're able to help with a system like what we've built is by offering a cash-based rate outside of the contracts that you have with your current third-party payers, we can potentially help reduce your bad debt that you're not going to collect any funds on for the patient responsibility side. So think about us as a solution for the high deductible health plan patients or the cash pay patients that you have that you're going to run those tests and you're just never going to collect on them. I think the average is 3 to 7% that high complex labs end up seeing back from the patient responsibility after the test has been ran. Dr. Farkas has asked, are tests CLIA classified as high complexity even legal as direct-to-consumer offering, even in the states that allow direct-to-consumer testing? So the CLIA certification on your laboratory, you should be designated as a high complex lab if you're running a high complex lab tests. Okay, so the direct-to-consumer testing world, and once again, attorneys will do a better job answering this, but I think there's a little bit of a blending different aspects of the business model. You can be a high complex CLIA laboratory and partner with somebody like ARCpoint in order to provide direct-to-consumer diagnostic testing. They're kind of two different worlds, and I do think that a 12-gene profiling test ordered by a patient. Remember, the system that we're talking about is considered direct access testing, but in reality, it's patient-initiated testing. It's still going through a prescriptive authority of a clinician that is ordering that test. So yes, in all 50 states, a 12-gene profiling test can be patient-initiated, go to an ordering practitioner virtually for that requisition to then have an ordering practitioner by the time that it ends up in your laboratory information management system.
John, I've seen one question that touches a little bit on the FDA's recent proposal on LTD oversight, and that's been a real big pet issue for us here at Lighthouse too. Obviously, it's really early in that proposal and really early as to how that might develop yet. But have you guys had any chance to, I suppose what I should ask is, are labs interested in a direct-to-consumer offering? Should they be watching that proposal? Is that something that stands to impact this market?
Say that one more time.
Yeah, if it's something that you've seen, the FDA within the last month dropped a proposed rule that would grant them oversight of LDTs, specifically reclassifying them as medical devices. And we've been doing a lot of advocacy here around that, asking people to reach out with public comments, how their lab could stand to be impacted. I just didn't know if that's something you're also watching on the direct-to-consumer front.
One of the things that we benefit from, I guess, is that we're the connection hub, we're the technology, and we're the brick and mortar to do the collections, right? And so the thing that we have the luxury of is we get to partner with all y'all that do the high complex lab work and have to deal with the FDA. I think it's a little bit outside of the scope of my knowledge to know what would be beneficial of the FDA starting to regulate lab developed tests. I think that became a really big deal during COVID, whether it was the point of care lateral flow tests or the processes that were ran as they were trying to get these things out to market. I'm a pretty good arguer. I could argue both sides of that if you are a lab that has high quality processes, awesome. Your competition's going to be cut down by the labs that don't want to offer that. If you're a smaller lab and you don't have the resources to go to the FDA and develop your own, it becomes a major issue for you. And I think that it could lengthen the innovation curve, and in fact, maybe decrease on the number of innovative tests that are hitting the market. So I think I could argue either way on whether that's good or bad. But the luxury that ARCpoint has is, listen, we just help labs connect themselves to consumers. That's kind of our secret sauce, and so we get to stay out of all those arguments.
Well, thanks for letting me put you on the spot there a little bit. And I think with that, we'll go ahead and give folks 5 minutes back of their hour here, and I'll wrap things up and just say thank you again to both John and Bob. Great presentation today, great information. And one final time, if anybody didn't get a chance to use that contact form and still has questions, please go ahead, click that button there, and you can fill it out, and we'll get that information over to them to follow up with you. But otherwise, thanks again, guys, and enjoy the rest of your afternoon.
Thank you for the time.
Thank you.